What's exciting to me is that we may, in the years ahead, get ahead of cancer like never before, because from this tube of blood in people who are at high risk, such as your genomic screen for predisposition variants in your genome or your family history, you'll be getting a assessment every 6 or 12 months for various proteins and gene variants. And that tube of blood could make the diagnosis of microscopic cancer before it ever would appear.
Welcome to our University of Hawaii at Manoa Better Tomorrow speaker series. Today's talk is entitled COVID-19 and the Future of Medicine. My name is Aimee Grace, and I direct Strategic Health Initiatives and Federal Affairs for the University of Hawaii system. I'm a pediatrician and formerly served as Health Policy Advisor to U.S. Senator Brian Schatz. As we know, 2020 has been a year like no other, marked by the impact of the COVID-19 pandemic. We've seen significant impacts and stress on our public health and healthcare systems, as well as many heroes rising to face these challenges and amazing ingenuity in biomedical research. We're honored today to feature Dr. Eric Topol, one of the most cited medical researchers in the United States and author of best-selling books, including Deep Medicine: How Artificial Intelligence Can Make Healthcare Human Again, The Creative Destruction of Medicine, and The Patient Will See You Now. Dr. Topol is the founder and director of Scripps Research Translational Institute. An expert in genomic and digital tools to individualize medicine, he is a lead researcher on the NIH's Precision Medicine Initiative and principal investigator of a flagship grant to promote medical innovation. We will speak with Dr. Topol for the first 30 minutes, followed by discussions with Dr. Randall Holcombe, director of the UH Cancer Center, and Lieutenant Governor Josh Green, who is also an emergency medicine physician. Our talk today will discuss how the greatest health crisis in a century will transform the future of medicine. We'll be talking about systems changes necessary to prepare for future emergencies, as well as the promise of genomics and artificial intelligence to transform medical research and practice. We'd like to now welcome Dr. Topol.
Oh, good to be with you.
Thank you so much for joining us today. I want to start by thanking you for your thoughtful advocacy for science throughout this COVID-19 pandemic, especially as we've seen many challenges to science in the current administration. For those of our viewers that aren't aware, Dr. Topol has played and continues to play a critical role as an agitator for the scientific process, transparent and free from political influence, particularly with regard to COVID-19 treatments and the vaccine development process. For example, Dr. Topol called strongly on FDA Commissioner Stephen Hahn to ensure scientific integrity in reporting results of trials related to treatments for COVID-19. Dr. Topol pressured Pfizer's board members to ensure transparency and scientific validity in the reporting of its trials. This session is about COVID and the future of medicine. We've certainly seen some of that future come into view with the incredibly rapid development of new vaccines, some of them using entirely new technology. Dr. Topol, you tweeted in the end of November this statement about the COVID-19 vaccine development process. This will go down in history as one of science and medical research's greatest achievements, perhaps the most impressive. I'd love to start with your thoughts on the COVID-19 vaccine development process. That tweet sounds like glowing praise, but I know you had some significant concerns with a number of aspects of this process, and you advocated hard during the process to try to keep it on track. Can you tell us more about those concerns? And how did you work with FDA Director Stephen Hahn and Pfizer and others to ensure a scientifically sound process free from political influence?
Well, thanks very much, Aimee. And I think it is a really interesting story, which I never thought I'd have a role in. But what happened was, back in September, we were starting to hear from both Pfizer, the CEO, and also from Donald Trump, that we were going to have a vaccine approved in October, so-called EUA, emergency use authorization, which the criteria for that is just may be effective, which almost anything would fulfill that. So the concern was that we would have that done prematurely, and everything was, hinged on that for the potential to get out of this pandemic crisis that we're in. So what was interesting is that when I wrote a letter to Stephen Hahn, the FDA commissioner, that was, of course, about the press conference in August about convalescent plasma and how that was a real debacle, how they claimed it had this ridiculous mortality reduction when there was none, and they had this so-called very historic breakthrough press conference. So when I wrote that letter, an open letter to him, I asked for his resignation or to tell us the truth of how he was pressured and strong-armed to do that. Because essentially, up until then, the FDA had been subjugated to the White House and to Trump. So what I didn't expect was that Steve Hahn would call me a few days later and tell me that he was really in despair and that he felt horrible how that went. And he was willing to be fired to do the right thing because he knew, like everyone knows, that the vaccine was the big one. And, missteps about hydroxychloroquine or convalescent plasma was nothing compared to the vaccine. So what could have happened is that Pfizer, on their first interim analysis of 32 events, could have basically declared it a winner, and it would have gotten approval, and it could have bypassed the FDA. The statutes in the government say the HHS, like Secretary Azar, could make an approval without even going through the FDA or any review. So basically what happened was Hahn got really strong, restored the FDA trust and confidence. He demanded from the manufacturers that the data were tightened that would fulfill an EUA. This led to big conflicts with Trump and the White House and Azar, but it all was for a good result because now we know we have two very effective vaccines. In fact, far better than we ever had envisioned, and we can trust the results. And as you well know, it's the trust of the public that's so vital here. So I give credit to Steve Hahn and the FDA people for standing up for this and standing up to Trump, who is bullying them. And the only other thing that I was able to successfully do was to push the protocols out of the manufacturers because they weren't going to make them public. The data plans, the sample sizes, the interim analyses, all the details. And fortunately, through continuous pressure through social media, they ultimately, once Moderna did it, then they all did it. And that was very helpful because then in advance, we knew what the issues were. So that was how we basically got this thing on track. And it is really an extraordinary, in all the years of watching science and medicine, nothing has been like this, just when we needed it, of course.
Well, thank you so much for sharing that story. And I know I and many others have been very inspired by that. I'm a pediatrician turned into a health policy person. And I feel like I see perhaps no more than these days how important health policy is for our public health. And something I want to hone in on is what you talked about, trust. Certainly trust is really critical these days as everyone is thinking about taking the vaccine. You're a very respected physician and author and researcher. Just to hear you say it, do you feel like you have trust in this process now after, speaking with Commissioner Hahn and how they've released the data, that you have confidence for the public to take the vaccine?
Absolutely. I wish I could have had my first shot already. No, I feel very good. I mean, there's two. Both today is the review of Moderna, of course, by the external panel. But we have two phenomenal vaccines that, actually one of my colleagues, Dennis Burton, and I wrote about as superhuman potential. That is, if you look at the antibody response, it's better than the typical human. It's amazing, actually. So there's only one other virus that has this vaccine profile. It's HPV. We're very lucky because it turns out this spike protein is just so ideal for a target. So no, we're going to see some safety issues emerge that didn't crop up in the trials like we saw in Alaska yesterday. But that's to be expected because you've got in the 2 trials so far, you got 74,000 people. In the real world, we have hundreds of millions. So we're going to see some occasional things that we're not seeing in the trials. Trials are not the same as you well know, real world. But those so far have been treatable, and the allergic reactions, people have done well. And if that's the worst we see, that would be great. But no, I'm totally, as far as the efficacy, it's extraordinary. And I'm hoping the durability, that is more than a year even, which is exciting. One other point about the concern about the vaccine is, was it going to suppress us from being carriers? That is, prevent the illness, but let the virus reside in our nasal mucosa. And it turns out we're seeing some good data, especially from Moderna and also some from AstraZeneca, that looks like it's going to work pretty well against us being these asymptomatic carriers. We don't know for sure, but it looks like at least 70, 80% protection, maybe even full protection. And that's good, because the sooner we can get rid of masks and get population immunity, the better.
Mm-hmm. Absolutely. Thank you so much for that. It's really critical. And you've been talking about the mRNA vaccine, and really that is a tremendous groundbreaking technology. I'm wondering if you can speak to that. And, we know that, years of research and experience went into making this success possible this year. Can you speak to how groundbreaking this is, and also with comparison to other vaccines that have faltered, say with HIV? Why is this so different?
Yeah, well, one was, of course, the target. It turns out we didn't know this. Most clinical trials fail, so we didn't know this was not just going to be a winner, but, big time winner. But the mRNA story is really interesting because it goes back almost 40 years. The idea that you could inject mRNA and you could, treat cancer or rare diseases or potentially a vaccine. What was interesting here is the NIH and some companies were already working on mRNA vaccines before this pandemic started. The key here was not just the mRNA, which we knew we could elicit something like an immune response, but how to package it in these lipid nanoparticles so that it would then, when it gets into the muscle in the arm, that it would start a process of, a cascade of a really good immune reaction. So as it turned out, it was all kind of primed up. The world was all ready to try it. So when the sequence of the virus on January 10th was shared by the Chinese researcher who got, really got a lot of grief in China for doing this. But fortunately for the rest of the world, that, really accelerated the whole process. As soon as the sequence was known, within days, there was an mRNA template vaccine, and it was going into production to get started and eventually, quickly go into trials. So it wasn't just the mRNA itself for the spike protein. It was also the nanoparticles. And there's one other feature that's fascinating, and that is back in 2017, there was this paper published. It's from Scripps Research from my colleague Andrew Ward, NIH, and many others, McClellan. And what it showed was you couldn't just give mRNA for the spike protein for a coronavirus. This is not, of course, for the current COVID, but for other coronaviruses like MERS. Because if you did that, it would there's a conformation of the spike protein when it goes in the cell. And so basically it wouldn't work. So what they did is they found the secret of, if you just substitute 2 prolines in the sequence, it would get in the cell, like a Trojan horse, and it would not, the conformation wouldn't be an issue. And then you get this dramatic immune response. So the key here was the incorporation of this 2 proline substitution. It's historic, and it's in the mRNA vaccines, both of them. It's also in the Johnson & Johnson vaccine and the Novavax vaccines. They all 4 have that. And those 2 Ps, remember that's a big deal.
Oh, amazing. I mean, it just speaks to how incredible biomedical research is, right, as we know, and really the promise and why it's so important here in the U.S. and here in Hawaii, too. And we'll look forward to speaking about, some of what UH is doing on this front as well. But actually, maybe I'll just pivot to speaking a little bit about genomics, since that's what you brought up, and really the promise of working with genomic medicine to have real breakthroughs. Can you speak to some of the other areas that you're seeing genomics really play a role?
Well, it's having across the board impact. Cancer is obviously, since it's a genomic disease, more and more sequencing is helping to guide the therapy and the follow-up of patients to respond to the therapies. So, I think we're seeing it there. And what's exciting to me is that we may, in the years ahead, get ahead of cancer like never before, because from this tube of blood in people who are at high risk, such as your genomic screen for predisposition variants in your genome or your family history, you'll be getting a assessment every 6 or 12 months for various proteins and gene variants. And that tube of blood could make the diagnosis of microscopic cancer before it ever would appear. And people don't die of cancer from cancer per se until it metastasizes. So we could really see an enormous impact in cancer. Obviously, the whole outbreak of the pandemic was a breakthrough in genomic sequencing because we can follow in time and in space everything about this virus, which is extraordinary. So we can, know a lot about super spreaders and, wherever, if there's a change, a mutation of a strain, all that sort of thing. The other area that's exciting is, of course, in unknown diseases. And that includes even people who have sudden death of unknown cause. But there's a lot of people walking around with rare or unknown diseases, and we can quickly crack the case with sequencing and related genomic assessment. So it's the biggest one of all, of course, is in maternal fetal health, because you can diagnose any chromosomal abnormalities of the fetus in advance, just at 10 to 12 weeks. So that's changed. The numbers of amniocenteses that are required now has gone to historic lows and may ultimately almost go to zero. So genomic medicine is across the board having a big impact.
Mm-hmm. Amazing. No, thanks so much for that. And I know you're also playing a key role in precision medicine with the NIH. And right, a lot of that has to do with individualized medicine that takes into account a number of these different genetic factors, environmental factors, lifestyle factors, and others. Can you speak to how you're involved with precision medicine with the NIH and the Olivis study, and how others may be able to get involved?
Sure. Well, we encourage everyone to be in all of us. We have just short of 400,000 people of the desired million-person cohort of participants. And just this week, the first group were getting back their genomic data, some of their genomic data. But the whole idea here is to get a million plus citizen scientists, diverse scientists, and that's actually the largest study with the best diversity so far in history. So it's a very ambitious program. And the idea is that, that people will get far more data about themselves than would be normal, with sensors, with their genome, with their microbiome, with all sorts of, in their environment, quantify, so that they can learn about themselves in this new way of medicine. Because ultimately, where we're headed is to have, if you want, and you're a kind of the citizen scientist type, you would use your data to guide you to prevent illness or to treat it better. So you'd be part of this story, not just, the one-off visit to a doctor, but rather you'd be, taking a real-time role in the management or prevention. And that's where I think this whole field is headed.
Awesome. And, it's really fascinating. I admittedly didn't know that much about artificial intelligence, or deep learning, as you call it, before I was, reading more about some of your work. And so I'd love for you to share some of those examples, as we're really kind of thinking about the future of medicine, this genomic-based, personalized medicine. What does it look like in terms of using artificial intelligence? A lot of us think about robots controlling the world, but I really have appreciated that you have really not lost sight ever of the patient or of the provider, even of the importance of the empathy of the provider working in partnership with any sort of deep learning. One example I thought was particularly compelling, and I hope you can speak to, maybe you can describe a little bit about what deep learning is, and then maybe the example in the mental health space. How can we use it so that we can see how we can better treat patients who have mental health disorders?
Sure. Well, AI has been around for a long time, 50 plus years, but only in the recent years, really the last 4 or 5, has the deep learning subtype come along, which is basically taking inputs, whether it's images like medical scans or speech or text, massive data sets, and being able to get outputs that give interpretation as good as people could do. And so there's neural networks, these deep neural networks are really extraordinary. Now, what's the promise, of course, is the immediate thing is that we're already seeing is improving accuracy. So scans that a radiologist might look at, or eye photos of the retina, or OCTs of the retina, or electrocardiograms, all the things that we use in medicine every day of patterns. Now, what you're bringing up is another exciting area in mental health, because up until now, we haven't had a quantitative, objective way of assessing a state of mind. And since depression is the singular biggest burden in health, as well as other mental health conditions, the fact that we could track a person by their speech, their breathing pattern, so many other ways that we could actually in real time, without passively, like the way they type on a text or on a phone or keyboard. So there's all these different ways. And the point being here is we're getting to an objective assessment of state of mind. And that will help in terms of being able to, whether it's with changes of cognitive behavior therapy, or if it requires medications, or whatever it takes to each individual to hopefully get to a better state when they are depressed, to try to prevent that, to manage it better. Obviously, the stress of the pandemic has been an enormous toll on everyone. But now we have new ways to counter that. But frankly, I'm not as excited about that and the accuracy as I am about the gift of time. Because today we have so limited time with patients. And it's just, it's really horrible how this has degraded the relationship over the years. And with the promise of AI and deep learning is that we give back time to the patients and doctor relationship and all clinicians, because there's get rid of keyboards, liberate, because we can use voice. And we can use so many parts of this, which I reviewed in the Deep Medicine book, where this gift of time starts back the human bond. And when we get together, we don't have this 7 minutes or 9 minutes, but we have a time to listen and not interrupt, and develop trust and a presence and empathy and communication, all the things that are the essence of medicine, in counter to the burnout and depression of clinicians that we have today.
Yeah, thank you so much, and certainly critical across the nation and here in Hawaii as well. I wonder if you can give a few more examples. I know you mentioned radiology, ophthalmology, gastroenterology, some of the ways deep learning can really manifest for maybe some of us that aren't as familiar with it.
Well, you mentioned gastroenterology, and that was kind of surprising how that bubbled up to be one of the top ones, because already it's being used in many places, like in Japan and China and other, where during the colonoscopy, there's a machine vision so that the gastroenterologist doesn't miss polyps. And in real time, it tells the gastroenterologist, is this likely cancerous or not, so they can guide whether to do a biopsy. So unnecessary biopsies are prevented. So it's actually fascinating to see that. Ophthalmology has led the charge in AI so far. A lot of people think it's radiologists, but the highest quality research has been in ophthalmology. And what's fascinating there is that in the retina pictures, it's not just learning about eye diseases. We can know about a person's blood pressure management, their diabetes management, their kidney disease, whether they are at risk for Alzheimer's or progressing. I mean, it's extraordinary, because these are things we can't see. But through trained deep neural networks with large data sets that are carefully annotated, we train the machines to see things that we can. And it's pretty impressive what we can get out of that.
It all sounds amazing. I mean, a real, promise for the future. I'm wondering the time horizon that you're looking at. When are we expected to sort of see this more commonly? And we'll turn a little bit later to telehealth. I know that's something that's how I first heard your name years ago when I worked for Senator Schatz, working on telehealth legislation. Telehealth is something we've kind of heard about the promise for a lot of years. We've been waiting to kind of see it really realized, and nothing has accelerated it like this COVID-19 pandemic. But I'm wondering in the AI and deep learning space, is it sort of similar where we'll kind of have the promise for a while until it really takes off? Or what do you see as that process?
Well, that's a great point, Aimee, because it always takes longer than it should, unfortunately. But I'm optimistic that it's already taking hold. It's still the early days. So, I mean, we have to keep that in perspective. But, certainly these algorithms are being adopted certainly in radiology is one of the front runners in terms of actual practical adoption. So I think we will see gradually, not like a light switch, the adoption. And what we're missing are, really rigorous, like randomized trials or prospective trials. But there has been, for example, a prospective trial in diabetic retinopathy. And you can go into many grocery stores now throughout the US, and if you're a diabetic, you can get a screen with no doctor, just, with basically an untrained person and algorithm. And half of diabetic people until now were never screened for retinopathy, the leading cause of preventable blindness. So, just think we have made some advances, and they're usually associated when we've done really good prospective trial work. We need more of that.
Mm-hmm. No, I really appreciate that. And maybe to kind of segue also into the telehealth discussion, I know you've been a leader for years in that space. Can you speak to how you've seen that evolve through the COVID-19 pandemic and what you see as the future of medicine with regard to telehealth?
Well, it took a pandemic for people to believe there's such a thing as telehealth. It was used very marginally before, and it was embraced when we had to have physical distancing. And there was no other out for people to get seen, really, unless they went to an emergency room. People were afraid to go to the hospital. Now we're seeing that back off a little bit because people, are able to go in for regular appointments and that sort of thing. But what was great about it is we learned the positives. And the fact is it's so easy and quick. And right now it's just a video chat, essentially, unless you have a skin rash or there's something you can show during the encounter. But the things that are really good about it is, one, you see a patient in their home environment usually, and that's something you wouldn't otherwise see. The other is that because of the practical aspects of how quick and get rid of all these other intermediate unnecessary steps. But what we're going to see is this telemedicine 2.0, which is objective data that's shared from the patient, either before the visit or during the visit, such as sensor data, imaging data, results of labs, whatever. And so it'll start to get more objective. And believe it or not, there's a way that the physical exam can be done almost in its entirety. And that's in the future as well by the patient during the encounter. So telemedicine is it got big legs during this. It's kind of a silver lining, if there are any, in this whole crisis. But, I think it's here to stay. It's going to be used not for the most serious matters, but for the simple, more routine thing. And the good thing is it'll decompress, so we'll have more time for the important stuff to be together, which is essential.
Mm-hmm. Well, amazing. And we've talked about a lot of different potential technologies and a lot of the biomedical research that has gone behind them. An area of importance, I know to you and to many of us across Hawaii, is addressing health disparities and making sure that we improve access to healthcare in a lot of our rural and underserved areas, especially on our neighbor islands. So I wonder if you can speak to some of the advances that you've been discussing, whether it's AI, deep learning, telemedicine, precision medicine. How can we leverage those technologies to serve those who are most in need and address some of the health disparities and work towards health equity?
Right. Well, this has been another thing that was exposed during the pandemic, is the inequities, inequalities and the people who have suffered the most as a result of that, because we don't have universal health care. and we have to get that. But while we're waiting, which has been waiting far too long, the good part is that a lot of these things we're discussing are inexpensive. And actually, I believe should be given to people for free if they can't afford it. So, for example, if you give a person who can't afford a smartphone and a data plan and apps that would help their particular health condition, that's a lot cheaper than one visit to the emergency room. You could give them 2 years of a data plan and a smartphone, and still would be cheaper than one night in a hospital. So we're not taking advantage of that. These things, these are software issues. They're inexpensive. And so, much of what we're talking about here, like, for example, smartphone ultrasound, which is my favorite technology. You can image people in the hinterlands, in Africa and India and many places, and by an untrained person. And that can be the acquisition of the image is guided by AI, and then the interpretation. So we're seeing technology reach places that heretofore was impossible. So I'm optimistic. It's clear that AI could make things worse, but it also could make things much better. And I'm hoping if we are smart about this, we'll go on the better side.
Really appreciate that. And certainly, right, there's the promise and all of the great potential outcomes, and also some of the perils, right? And I'm sure folks have concerns about whether that's privacy and access and all those issues that unfortunately we don't have time to get into today. This has gone so quickly. But Dr. Topol, really appreciate, all of your hard work, all of your work in national policy and on the biomedical research side, and really your vision for the future and how we're going to get there and how we can work together to do it. So thank you so much for being with us today. And we're going to transition to speak on some of the local levels. We're going to talk to Dr. Randall Holcombe next from our Cancer Center to understand some of the work that we're doing here and how it relates to what you've been talking about. Thank you so much for your time.
Thank you so much, Dr. Grace. Really enjoyed the discussion.
Thank you. I'd like to bring on Dr. Randall Holcombe. As I mentioned, he's the director of the Cancer Center. Dr. Holcombe, we know that a lot of these sorts of advances in precision medicine and genomics and AI and deep learning are global, right, on a much bigger scale, but we're doing a lot of them here. And I'd love for you to be able to share some of what we're doing here at for our communities in some of these areas.
Well, Aimee, thank you so much for the opportunity to talk here today. You're correct. Some of the really exciting things that Dr. Topol was talking about are being researched right now at the University of Hawaii, which is incredibly exciting and I think will be very beneficial for the people across the state. So a few things that you asked about, I'll touch on. Precision medicine and using genomics to guide care. We're in the process with our community partners in the Hawaii Cancer Consortium. That's Queens, all the HPH hospitals, Kuakini, Castle Medical Center, as well as HMSA and JAPSOM. We're in the process of building an early phase clinical research center. This will be a location where cancer patients who primarily have failed standard therapies will have access to phase 1 or early phase type trials. This is really something long overdue. Patients in Hawaii have either not had access or have had to travel to the mainland for this type of access to these novel trials. So we really want to offer that here at home. But the really exciting thing is that these types of trials used to have a very low chance of patients having a response. They used to be just designed to measure for toxicity of new medications. But with the era of precision medicine, we now target these specific trials for individuals with specific gene mutations in their cancer. And the response rates, even for these very novel experimental drugs, can be up to 40%. Which is actually better than a lot of standard chemotherapies that we give to patients for many diseases. So I think it's really exciting. It's a new era for early phase trials. And this is a collaborative effort really from entities across the state. And I think will be something that will really benefit cancer patients here in Hawaii.
Terrific. I really appreciate that. And I know you've really led the charge for a number of years on that. So that's really exciting. Can you also speak, I know we're doing a lot at the Cancer Center in terms of imaging, and especially, for example, with breast cancer. What are some of the advances in some of the spaces around imaging, and what are the advances that we expect to see?
Well, one thing I can comment on is some of the work being led by Dr. John Shepard here at the Cancer Center, utilizing artificial intelligence to improve detection of breast cancers, especially in young women with dense breasts, because mammography is not so great for that. And he is working to establish what's called our Pacific Mammography Registry, and collecting mammographic images from across Hawaii and areas across the Pacific, including Guam, so that he can utilize artificial intelligence to better predict abnormalities that may otherwise not be detected by routine mammographic screening. The reason this is important for us here is because most of this work has been done on the mainland, mostly with white and sometimes African-American populations, but has not been focused on the races and ethnicities that we have here in Hawaii and across the Pacific. And it's crucially important to do the work here, because otherwise we're not going to know whether new artificial intelligence paradigms are actually going to work for our population here. So it's important to do the work here. And I think this is, again, a very collaborative effort. Involves lots of different institutions, and will really benefit the people of Hawaii and people of the greater Pacific.
Yeah, thank you so much. And you really spoke to, I know we do a lot of research with regard to racial and ethnic differences and disparities. And I wonder if you can speak to that, because as we know, this is thankfully becoming more of an issue nationally, as we want to make sure that a lot of these advances don't leave anybody behind. At Cancer Center, we have the multi-ethnic cohort, as we know. We also have a lot of the cancer programs in the Pacific. I wonder if you can speak more to those and sort of the decades of work that has been doing to really advance this science.
So I love to talk about this, Aimee, because this is really the primary focus of our cancer center in understanding the risk factors for cancer and what factors may modulate response to treatment in different racial and ethnic populations here in Hawaii and across the Pacific. The multi-ethnic cohort, as you noted, has been ongoing for over 25 years now, following patients here in Hawaii and also in Southern California. We've had some tremendous discoveries from that. So just as an example, we have found that something called a polymorphism in a gene that is involved in nicotine metabolism differs across people from different racial backgrounds and different ethnicities. And we found that Native Hawaiians and African Americans are more at risk for lung cancer because their type of gene that they have that metabolizes nicotine actually metabolizes nicotine more quickly. And when it metabolizes it more quickly, then people inhale more deeply and get more smoke into the lungs, exposing their lung tissue to more carcinogens, and therefore the risk of cancer is higher. The reason this is important is because we think that the screening guidelines for lung cancer should be different across different groups depending upon what kind of polymorphism they have in that particular gene. So we're doing research to try to investigate that further. Another example is that we found that an abnormality on chromosome 6 in Japanese Americans and Native Hawaiians leads to an increased accumulation of fat in the liver. Even if people are not obese, they get increased fat in the liver. Fat in the liver is not a good thing because it can predispose to the development of liver cancer. And Hawaii is second among all the states in the incidence of liver cancer. So this is a crucial problem here. So those are just two examples of some of the research going on here, where we're looking at different populations. We are studying what the risk factors are for the development of cancer. And I think we'll have really significant public health implications in determining how we screen for cancer and also how we implement cancer prevention interventions.
No, thank you so much. And it's really exciting to think about the future of cancer care. And, as we know, we've been all subsumed in this COVID-19 pandemic, but there's so much going on, especially in these chronic diseases that continue. The innovations in cancer care are going to be really important. We had one question from the audience about how are some of the innovations from COVID, or are there new findings from during the COVID pandemic that are influencing how we're seeing cancer care? Or I'm just sort of wondering how we're going to be pivoting from COVID going forward into the future of cancer care.
So there are a few things. First, we're participating in several national studies looking at the effects of COVID on cancer patients. And we're enrolling cancer patients who develop COVID-19 onto these studies so that we can contribute to the database and try to understand what the implications are for cancer patients. We know that their immune systems are suppressed. We know that they can have more critical illness from COVID than other patients because of that. And so we're really trying to study that. We also know that nationally, including here in Hawaii, there has been a marked reduction in cancer screening because of the COVID-19 pandemic. That's because people didn't want to go to the hospital or to physicians' offices and get a colonoscopy or a mammogram or get their annual pap smear because they were scared about going. We understand that. But the incidence of cancer nationally has actually gone down, and we think it's artificial because we have missed lots of screening. And the concern is that now patients are going to present with a more advanced stage of cancer than they would have otherwise. And it's much more difficult to treat in that circumstance. So this, I think, has been a profound impact of COVID-19, and we really need to get back to cancer screening for our population. The last is that we're really interested in studying the long-term effects of COVID-19. Many people have talked about the long haulers, people who have had COVID-19 and have lots of symptoms left over. We know that it affects the lung, it can affect the heart, it can affect the liver. We don't know if the chronic inflammation that occurs in these individuals who have long-term symptoms from COVID-19 may predispose to the development of cancer at some future time. So we'd actually like to set up a similar study like our multi-ethnic cohort study and follow patients here in Hawaii who've had COVID-19 over a long period of time. So we're working to try to raise money to establish such a cohort. This is not an inexpensive thing to do, but we think it will provide incredibly important information about understanding the long-term effects of COVID-19.
Well, very exciting and so needed. And I mean, certainly that's something that we've seen throughout the pandemic is the need to shore up our public health systems, our healthcare systems, our biomedical research. It's certainly been a discussion on the national level as well as on the state level. I was wondering if you could speak to what public investments are really necessary to get this kind of biomedical research as strong as possible as we go forward to take care of the after effects of COVID.
Well, you're talking to a biomedical researcher, and so I'm always an advocate for investment into biomedical research. I think that the research that we do here in Hawaii is so critical because no one else is studying the populations here. And so if we just rely on research on the mainland, we're really going to miss out on a lot of very important information that relates to the development of cancer and cancer risk factors. Even from just an economic point of view, biomedical research provides a huge economic stimulus because researchers like myself get lots of money from outside of the state, from the federal government to support grants. The Cancer Center here brings in between $20 to $25 million every year in federal funding. And what that does is that supports people who are doing research in the laboratories. It pays salaries. It has about a $60 million economic impact, just the work that we're doing at the moment. So it's really a great investment to support research because it helps to diversify our economy and it provides a stimulus to the economy that is somewhat resistant to travel industry type of fluctuations that may be seen with things like the COVID-19 pandemic.
Great. Thank you so much, Dr. Holcombe. There's so much exciting going on at UH. And maybe I'll just finish with a question. Personally, as we think about the future of medicine, what are maybe some of the areas that most excite you personally about what you're seeing with regard to cancer care and where we're going to be going in the future and how we leverage, a lot of these different technologies to make sure that people in Hawaii and across the Pacific have the best care possible?
Well, I think that the new technologies are very exciting. We do have to address the cost of some of these new technologies to make sure that they're widely accessible. But I think that the more we learn about genomics and can apply precision medicine both to diagnosis and to treatment of diseases, chronic diseases, including cancer, I think the better we're going to do. We're going to have many more cancer survivors because we're able to control disease and keep it from spreading and metastasizing. So I think that's really exciting. And I think that from an informational technology point of view, the improvements in artificial intelligence have a great potential to reach individuals across the Pacific who otherwise might not have access to even simple things like mammograms. So many of the islands across the Pacific, you can't get a mammogram. So you can't do breast cancer screening. So I think that we need to develop other techniques that we can use artificial intelligence along with so that we can provide this type of cancer screening for low resource areas.
Great. Thank you so much, Dr. Holcombe, for your time today and for sharing really a lot of the amazing work that UH is doing. Really appreciate your time.
My pleasure. Thank you so much.
Great. Thank you. We're going to turn now to Lieutenant Governor Josh Green, who is also an emergency medicine physician and who has been leading the charge on many different COVID-related response efforts in the state of Hawaii. Welcome, Lieutenant Governor.
Aloha, Aimee. Thank you for having me.
Thanks so much for being part of this discussion about the future of medicine. Certainly, you've been very involved in not just thinking about the future, but certainly the present, and we really appreciate all of your efforts. We have been talking about a lot of different aspects, but I want to get back to vaccination because that's really front of mind for so many people. And again, it really builds on the decades of investments in biomedical research that we've seen across the United States and really the world, and genomics and precision medicine that we're thinking about. So can you speak to kind of where we're at with the vaccination efforts in the state? And especially, we know that some of the vaccines have already started. And what do we need to do as a state to get ready to make sure that everybody is vaccinated in good time? Who wants to be?
Well, thank you. Well, I'll just say this. As Dr. Topol suggested, it was a historic effort. It's so enormous, the number of people that worked on it and the number of clinicians like you and researchers like our cancer center and Dr. Holcombe. I mean, the whole world had to pull together in each of our disciplines to get this done. It was almost impossible, but the number of scientific hours put on it, I tell people this so that they're confident that we have a good product here and that will be safe. I would guess exceeds in every way the amount of time we've ever put into a single project in 10 months. And so it's amazing. And we're vaccinating people. As of the last 36 hours, we started vaccinating people here in our state, which is also amazing. We've spoken a lot about what it will take to turn the corner and see any kind of normalcy return, and that is the vaccination program. In the meanwhile, of course, it's going to be all of those things that seem so mundane, like wearing a mask, washing hands, socially distancing, which are absolutely critical for now and for a period of time still in the foreseeable future. But the vaccine will accelerate very quickly. We received 5 trays, essentially. A tray is 975 doses of the vaccine, 5 trays this week. And those are going to all go into, people like to say, shots in arms, right? And it's true. Those shots will be delivered in these first few days to healthcare providers and individuals that are otherwise very vulnerable. And it will surge upward. Next week, we will get twice that many. We expect to get over 80,000 doses in this first month. That's 80,000 of the first doses for what we call our 1A category, which are healthcare workers and our kupuna living in nursing facilities, long-term care homes, and so on. And though that may only represent about 10% of the total number of vaccines that we ultimately give in Hawaii to begin to reach herd immunity, to begin to be, immune as a whole state, it's critically important because, as you know, that means hospitals will be able to stay open. We won't have services threatened. It means that there won't be kind of bank shot transmission where an individual comes in sick with COVID, and no matter how good one tries to mask or socially distance, there are moments, especially as a healthcare provider, as you know very well, where you do get closer than 6 feet, obviously, in spite of the really quite extraordinary comments we were having about artificial intelligence, telehealth, and so on. Those are great advancements, but I'll be on call this weekend for, I think I'm doing a 60-hour shift this weekend, and it's there's no doubt that I will be in closer proximity to people, and I've already even had COVID. So the vaccination gives the healthcare community hope. We will not have that extra transmission. Healthcare workers will go home to their loved ones. You go back to your husband, or I go back and see Jamie or the kids or whatever. We can transmit disease to one another in the family. So it's an extraordinary thing. It will change the outcomes for the better. We have to maintain our vigilance. And this means that we can open up that sector of our kind of economy, our state. And then we move quickly into the next risk and the next risk group. And everything starts cascading positively from there. So I think that's going to be the kind of the shiny penny for people focusing on what's going on with COVID this year. It's amazing. I talked about mask wearing and testing almost nonstop so that it melts your brain for the last 90 days. And the minute the vaccine touched down, nobody asked me about those things anymore. It's what's the vaccine? What are we going to do? How's it going to work? Some people afraid, some people not. Most people excited to be a part of it. So that's a long way of saying it gives us hope, and it will be a big logistical lift. The science was an incredible lift, and now the logistics are going to be an incredible lift. And I can break that down for people, but 80,000 doses in the first category. Last night, we finalized what we believe will be the approach for critical infrastructure workers, which we'll wait to announce because we're still refining that with the team and our kapuna and so on. But everyone should know there is a plan. It's comprehensive. It will also seem a little chaotic, but each month over month, we'll get safer.
I really appreciate that. And certainly, as you mentioned, going from the bench to the bedside, right, and shots in arms, that's a whole process. And a lot of that has to do, at this point, with a lot of public trust. And I wonder if you can speak a little bit to, again, sort of like we spoke with Dr. Topol. Do you trust this vaccine? Are you planning to take this vaccine? And what would you say to the public about really, again, building on the decades of biomedical research that's gone into it, how you see it going forward?
Thank you. I do trust it. I will be vaccinated next week, it appears. I'm waiting my turn, of course. So I'm in a little bit of a weird spot because I'm not getting the vaccine because I'm a public official. I'm getting it because I'm on call and going to be going into care for others. I also had COVID 95 days ago. And so they're assessing where I should go because I don't want to take a vaccine out of the hands of someone else who has less immunity and is seeing more patients in the next couple of days. But yeah, I trust it. I think the science was extraordinary. I do know, I think like it was mentioned by Eric up front, that it likely will show some additional, we'll learn as we're vaccinating first 1 million, then 10 million, then 100 million people. Sure, there's an incredible amount of variability, like Dr. Holcombe points out, amongst different ethnicities, different peoples in Hawaii. My kids, for example, I'm so proud of his research and Randy's leadership at the Cancer Center, because when he says about mixed ethnicities and no one studies what we are in Hawaii, I think of my children, because I'm a Polish Russian guy married to a Japanese Hawaiian woman, and our children are an interesting hybrid version of all those ethnicities from Europe and from Asia and from here in Hawaii. So the research that's done at UH and the health sciences work, which really is to create a better tomorrow, not to be cliche about what this series is, it does focus on the very people that live here and that have very likely a different ethnicity and genetic makeup. So all these things bode well for us in Hawaii, but we'll learn and we'll be able to share what we learn. And hopefully the whole world will look like Hawaii someday with mixed ethnicity, so we can get over racism, we can get over different biases. But for now, this is the year, and this will be the way we get to safety. And when I get my shot, I'll probably broadcast it to show some people that we can trust it. But it's going to get us out of this this gigantic challenge.
Really appreciate that. That is really exciting, and I know a lot of health providers and others are super excited about the vaccine. So we so appreciate the all of the work that's gone into it from so many researchers and leaders and health policymakers. So one question, really looking forward, like we had mentioned, this is so critical in order to continue these investments for the future, right? We don't know what the future is going to hold. God forbid we'll have another pandemic, but you never know. What can we do as a state? We know that we're in really tough budgetary times. We know we're fighting to get back to tourism. But really, as Dr. Holcombe mentioned, the investments federally and investments in this sort of work is really important to help us get back on our feet, to diversify jobs, to make sure that we're combating the public health needs of the future. Can you speak to what we need to do as a state to make sure that we have a strong public health infrastructure, that we have a strong biomedical research infrastructure going forward?
I can, because I know we're coming up on the hour. We have to have a new mission in the way we approach Hawaii's economy, and it's something that I'm developing with my team already. The mission has to fortify itself, which is to say, when we do something, say in biomedical research, we have to know that it creates additional resources and jobs for young people that can then be here with excellent capacity to have a better life than being trapped in a small, narrow window where they can only do, and although I love tourism, only do tourism, be very vulnerable, have to sometimes bounce into Medicaid and needing incredible support if they don't have enough resources. Very expensive to live in Hawaii. So we have to create an economic ecosystem that's a lot better, which means high-tech health, advanced education, a Silicon Valley effort in health research, but in Hawaii-style ways. We have to be able to do, sustainable energy programs that replace some of the tourism sector so that we're way, way more resilient than if a virus hits us and you have to shut down. We immediately turned off 125 to 150,000 jobs immediately. Like a switch went off, and you see how catastrophic that was. Now, interestingly, when we started the Safe Travels program, we immediately turned the switch on and 29,000 jobs came back instantly like that, but they're equally vulnerable still if the surge got so bad or there's too many cases. So we have to be different next time. And it's not just that we're going to pull a mask out of a drawer and say, okay, we're safer. Although that wouldn't be the worst thing to do right off the bat if infection reared its head. But we have capacity like never before. And I think that it's the hardest lesson to learn this way, but we learned it just like we learned how fast you can bring telehealth online when people have to do it. So there's nothing like a have to create change.
Mm-hmm. Absolutely. And we're almost at the end, but maybe a quick question, Lieutenant Governor. Thank you again for all of your leadership in so many different ways. What are you most excited about in terms of the future of medicine and the future going forward, hopefully as we emerge from this COVID-19 pandemic? What makes you really hopeful looking forward?
Well, I'm hopeful because I saw that we could do essentially a moonshot project together as a globe. We haven't worked together this way in the foreseeable past. It has not happened at this level, or at least this visibly in my lifetime. I'm 50 now, and I know there's always some collaboration that goes on between different subsets of the scientific community. It's pretty amazing. But this particular time, the whole world had to bond together to stop a virus that was obviously an existential threat, both physically and economically. So now that we know that we can do it, I think that we will do it. It was not unlike when we went to Samoa and vaccinated a whole small country with just a group of 75 people, knowing that we could do that next time if we had to translate that into a state project or a national project. I think these examples are meaningful. And I'm sure that the collaboration will be better going forward. So we can start looking at cancer and immune-mediated diseases or whatever may come. And the community might just say, well, let's actually do this together to save many people in different countries.
I love that. The great note to end on: collaboration for a better future. Thank you so much, Lieutenant Governor Josh Green, UH Cancer Center Director Randy Holcombe, medical leader, author, researcher Dr. Eric Topol. And to all of you, thank you so much for being here today. We really appreciate it. I want to really thank our primary sponsors for UH's Better Tomorrow Speaker Series, which are Kamehameha Schools and Hawaii Community Foundation. I'd also like to thank our key sponsors of this event, Hawaii Pacific Health and the Queen's Health Systems. Thank you to our student staff, our UH's IT department, UH Communications, and the UH Alumni Relations for all of your support. And thank you all so much for taking the time to join us today. Aloha.